Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about squamous cell carcinoma. Definition: squamous cell carcinoma is a malignant neoplasm or keratinocytes. It is locally invasive and has the potential to metastasize. It appears clinically as a scaling patch, indurated plaque or nodule that sometimes bleeds or ulcerates. The etiology of squamous cell carcinoma includes UV radiation from sun exposure or tanning beds, chronic wounds or scars, chronic immunosuppression, and chemical carcinogens such as soot and arsenic. Squamous cell carcinoma: ulcerated, crusted, red plaque. Incidence: squamous cell carcinoma is the second most common skin cancer, with nearly 2 million new cases diagnosed each year in the United States. The incidence of squamous cell carcinoma varies greatly with reference to ethnic group, geographic location, and occupation. It is most common in men aged over 60 years who have light skin and abundant sunlight exposure. Closer to the equator, the incidence increases. In renal transplant patients, squamous cell carcinoma is 3.5 times more frequent than basal cell carcinoma and more than 250 times more common than in the general population. Some 9 years after renal transplantation, patients have a more than 40% incidence of squamous cell carcinoma. Squamous cell carcinoma is the second most common skin cancer after basal cell carcinoma. History: the patient's history of sunlight exposure in occupational and recreational activities is important in determining the risk of developing squamous cell carcinoma. A family history of skin cancer and a personal history of fair skin and sunburning are additional predisposing factors. The history of a chronic non-healing bleeding growth or ulcer should arouse suspicion of squamous cell carcinoma. Physical examination: squamous cell carcinoma occurs most often in sun-exposed skin. It also develops on the mucous membranes and in sites of chronic injury, such as burn scars, irradiated sites, erosive discoid lupus erythematosus, and osteomyelitis sinuses. The occurrence of squamous cell carcinoma varies with anatomic location. Head and neck 81%, upper extremities 16%, trunk 1.5%, and legs 1.3%. Most squamous cell carcinomas occur on the head, neck, and arms. The tumor nodule is hard red to flesh colored and has a smooth or verrucous surface. The central portion may be hyperkeratotic, ulcerated, or crusted. Deep invasion results in fixation to the underlying tissue. Squamous cell carcinoma of the lip involves the lower lip in 90% of cases and usually arises from a chronically damaged epithelium secondary to actinic exposure or smoking. A chronic scaling red patch may be a squamous cell carcinoma. Squamous cell carcinoma: slightly crusted hyperkeratotic plaque on the lower lip. In epidermis, hyperkeratosis and atypical keratinocytes are present. In dermis, invasion, tumor, and inflammation is present. Differential diagnosis: squamous cell carcinoma can be differentiated clinically or by biopsy from a keratoacanthoma, which may be a variant of a squamous cell carcinoma. Hypertrophic actinic keratosis, wart, lichenoid keratosis, basal cell carcinoma, and seborrheic keratosis. All persistent ulcers or crusted lesions must undergo a biopsy to rule out squamous cell carcinoma. Squamous cell carcinoma in situ or bone disease appears as a red, scaling, slightly crusted, well-marginated patch. Squamous cell carcinoma in situ of the glans penis is referred to as erythroplasia or kerat. It appears as a red, velvety, moist patch. Squamous cell carcinoma in situ: well-demarcated red, scaling, and slightly crusted patch. Erythroplasia occurred, red, velvety, and moist patch. Keratoacanthoma is a rapidly growing neoplasm of the epithelium that may be biologically benign but histologically resembles a squamous cell carcinoma and is thought by some to be a variant of squamous cell carcinoma. Keratoacanthoma is a round, flesh-colored nodule that characteristically grows rapidly within 4 to 6 weeks and has a central keratin-filled crater. Keratoacanthomas may spontaneously involute within 6 months. However, because some may be difficult to differentiate from squamous cell carcinoma, excision or other destructive treatment is recommended. Keratoacanthoma, rapidly growing pink nodule with a crusted hyperkeratotic central crater. The conclusion of differential diagnosis of squamous cell carcinoma include keratoacanthoma, hypertrophic actinic keratosis, wart, basal cell carcinoma, seborrheic keratosis, and lichenoid keratosis. Laboratory and biopsy. Any lesion suspected of being squamous cell carcinoma should undergo biopsy. Squamous cell carcinoma consists of malignant epidermal cells that invade the dermis. It is graded according to the degree of atypicality of the tumor cells, with grade 1 predominantly mature, whereas grade 2, 3, and 4 are less well differentiated. Grade 4 tumors may be difficult to differentiate from malignant melanoma because the spindle-shaped cells lack intercellular bridge. The biopsy of squamous cell carcinoma in situ or Bowen disease reveals a thickened epidermis consisting of atypical poly-oriented dysplastic cells that lie completely within the epidermis. Keratoacanthoma has a large central keratin-filled crater surrounded by well-differentiated epidermal cells that sometimes appear dysplastic, thus making it difficult to distinguish from a squamous cell carcinoma. Therapy. Sun protective measures such as the use of sunscreens, protective clothing, and avoiding midday UV light exposure are important for the prevention of future squamous cell carcinoma. Nicotinamide 500 mg twice a day is also effective in reducing squamous cell carcinoma. Excision is the treatment of choice, although a well-differentiated small squamous cell carcinoma occurring in actinically damaged skin may be effectively treated with curettage and electrodesiccation. Large or recurrent purely differentiated tumors, as well as those occurring on the mucous membrane and in scars, should be treated by scalpel excision with narrow margins 3 to 5 mm that are checked histologically to be free of tumor, or by the Mohs technique. Non-surgical therapy such as ionizing radiation is useful in selected patients. Intralesional methotrexate or 5-fluorouracil have been used in selective squamous cell carcinomas, especially keratoacanthomas. The immune checkpoint inhibitors, semiplimab and pembrolizumab, are both monoclonal antibodies and monoclonal antibody medications that bend the PD-1 and work by increasing the body's immune response to tumors. They are indicated for patients with locally advanced squamous cell carcinoma who are not candidates for curative surgery or radiation, and for metastatic cutaneous squamous cell carcinoma. The conclusion of therapy for squamous cell carcinoma. The first line is prevention: sunscreen with SPF 30 or greater reapplied after a couple of hours, broad-brimmed hat, long-sleeved shirt and pants, avoidance of intense midday sun from 10 a.m. to 2 p.m., and nicotinamide 500 mg twice a day. Initial therapy include excision, curettage, and electrodesiccation, most micrographic surgery. An alternative therapy include radiation, intralesional methotrexate or 5-fluorouracil, immunotherapy, and chemotherapy. Course and complications. The course of squamous cell carcinoma is variable. Those carcinomas most likely to metastasize are relatively large, fully differentiated, invade more deeply, including preneural and lymphovascular invasion, occur in damaged skin and mucous membranes and in an immunosuppressed patients. Some 2% of all squamous cell carcinomas of the skin metastasize. Those that arise in actinic keratosis are less aggressive with a metastatic rate of 0.5%. Much higher rates of metastasis, up to 9%, occur in squamous cell carcinoma arising in chronic leg ulcers, burn scars, radiodermatitis, osteomyelitis, sinuses, and the mucous membrane of the lips, glans, penis, and vulva. When metastasis occurs, it is usually through the lymphatics to the regional lymph nodes. Prophylactic lymph node dissection is not done unless the patient has lymphadenopathy. Note, squamous cell carcinoma arising in actinic keratosis has a low metastatic potential, 0.5%. Note, high-risk features include large size, more than 2 cm, depth more than 2 mm, perineural or lymphovascular invasion, ear or mucous membrane, recurrent tumor, immunosuppression, and pure differentiation. Pathogenesis, Sir Percival Pott, I hope I'm reading the name of the scientist correctly. Sir Percival Pott in 1775 was the first to describe occupationally induced cancer and to relate cancer to an etiologic agent. He described the occurrence of squamous cell carcinoma of the scrotum in chimney sweeps and suggested that its cause was chronic soot exposure. In 1901, Lambel related squamous cell carcinoma to arsenic in drinking water. The relationship between UV radiation and squamous cell carcinoma was suggested in 1875 by Tirsch. Freeban in 1902 described the occurrence of squamous cell carcinoma after exposure to X-rays. Experimentally, Yamagiwa and Ichikawa in 1915 were the first to produce squamous cell carcinoma in mice and rabbits after the topical application of coal tar. Several years later, in 1924, Bloch induced squamous cell carcinoma in rabbits after X-irradiation. Using mice repeatedly exposed to UV radiation, Findlay in 1928 was the first to produce UV radiation-induced carcinoma. Human papillomavirus HPV has been implicated as the cause of cutaneous and cervical carcinoma. Patients with epidermal dysplasia verruciformis, a rare genetic disorder, develop hundreds of flat warts, and those warts caused by specific types of HPV, particularly HPV-5 and HPV type 8, are prone to transform into squamous cell carcinoma. The finding of HPV-16 and 18 genomes in carcinoma of the cervix has provided strong circumstantial evidence for HPV carcinogenic potential. All of these carcinogens, UV radiation, X-irradiation, coal tar, arsenic, and viruses, are active in the skin, initiating malignancy by altering cellular DNA, RNA, and proteins. In addition, UV radiation also alters the immune system, making the host most susceptible to these tumors. Chronic immunosuppression, as occurs in organ transplant recipients, is also associated with an increased frequency of squamous cell carcinoma, especially in sun-damaged skin. Clinical case: a 72-year-old retired fisherman with a history of chronic sun exposure presents to the dermatology clinic with a concern about a growth on his lower lip. He reports that it first appeared as a small scaly patch about 8 months ago, but has been steadily increasing in size. It occasionally bleeds when he shaves and has become slightly painful. He has a 40-pack-year smoking history and drinks 2 to 3 beers daily. On physical examination, you find a 1.5 cm frame hyperkeratotic indurated nodule with a central ulceration and rolled borders on the vermilion border of his lower lip. There is no cervical or submental lymphadenopathy. A shave biopsy of the lesion is performed and the histopathology report describes nests or atypical keratinocytes with horn pills invading the dermis. Based on the case above, which of the following is the most significant risk factor for the development and aggressive nature of this patient's conditions? A. His 40-year smoking history. B. His daily alcohol consumption. C. The location of the lesion on the vermilion border of the lip. D. His occupational history of chronic sun exposure. And E. The size of the lesion being greater than 1 cm. The correct answer is the location of the lesion on the vermilion border of the lip, and we are going to explain about it. Explanation. While all the options listed are relevant risk factors for cutaneous squamous cell carcinoma, the location of the vermilion border of the lip is the most significant in this specific context. This error is classified as a high-risk mask error of the face, central face, eyelids, eyebrows, periorbital nose, lip, chin, mandible, preauricular and postauricular skin, sulci, temple, ear. Cancers in this location, particularly the lip, are considered high risk due to several factors. Thin epidermis and rich lymphatic drainage. This anatomy facilitates local invasion and regional metastasis. Functional and cosmetic importance. Invasion can affect speech, eating, and appearance. Higher metastatic potential. Squamous cell carcinoma of the lip has a higher rate of recurrence and metastasis compared to squamous cell carcinoma on many other parts of the body. The biopsy finding of horn pills is a classic histopathological feature of well-differentiated squamous cell carcinoma. Okay, this was an explanation about squamous cell carcinoma. Thank you for your attention.